So this is a 72-year-old man with a history of ischemic cardiomyopathy. He has a history of 3 coronary bypass surgeries, 3 independent cabbages in the past, who has worsening heart failure. His EF is 20 to 24% by echo. He's now having worsening shortness of breath at rest. He has 2-pillow orthopnea, denies chest discomfort. He has no peripheral edema. And he's had 2 hospitalizations in the last year for acute decompensated heart failure. His medical history, as noted, is that of heart failure with reduced EF. He does have a biventricular ICD and is paced. Significant coronary disease. He had a cabbage at an outside hospital in 1990, a cabbage again in 1998, and a 3rd cabbage in 2004. He has diabetes, which he's had for 20 years, now requiring insulin, but without any significant end organ complications, hypothyroidism, and a former smoker. So we don't have any specific information about his first bypass since it was done elsewhere, but his second bypass notes that he has a Lima to the LAD, and he has a vein graft to the PDA and a graft to the ramus and distal circ. And then the redo in 2004, he again has the Lima, and he has a graft to the ramus, and that this time it's a left radial artery graft. And again, he has a graft to the PDA as well.
Laurie, just one thing, that's on the 3rd operation in 2004, it was actually the right internal mammary artery.
Yes, so it's not here, but then so on his most recent coronary angiogram, he already.
So that's 2 mammaries.
Huh?
2 mammaries.
That's an important.
Both mammaries were used, right?
Yes, they were used.
And 1 radial.
So he does, at some point there was a Rhema, so it was the 3rd cabbage that was the Rhema. He has an occluded left main in terms of his native anatomy, occluded right, but he has a patent saphenous jump graft going to the mid to distal LAD and to the OM. His Lima is described as being functionally ineffective, and he has a Rhema to the ramus. So his medications, he's on maximally tolerated medical therapy, which for him is metoprolol, succinate, 25 milligrams a day, lisinopril, 10 milligrams daily. He's on spironolactone, digoxin, aspirin, statin, and diuretic. On exam, notable things, his blood pressure is 98/60, his heart rate is 71, and he's paced, biventricular paced. And on exam, he has no elevation of his JVP at this time. He does have an S3 gallop. His lungs are clear, his extremities are relatively warm, and he has no peripheral edema. Labs are pretty good, or not bad. Things of note, his creatinine's 1.3, but he has a GFR of 54 milliliters per minute. The lower left is the hepatic panel. So his transaminases are within normal limits. His bilirubin is 0.8, and his total protein and albumin are normal. No coagulopathy. He has a history of hypothyroidism, so his TSH is normal. His diabetes is well controlled. And going back to the creatinine of 1.3, his UA shows no proteinuria. He did have a nuclear stress that showed 23% scar burden, less than 10% ischemia. Other labs and data, blood type O, PRAs are 0% for both class 1 and 2, and other serologies are essentially unremarkable. Other data in terms of his advanced therapies evaluation, his CPET, his peak VO2 is about 10 milliliters per kilo per minute. with an RER of 1.1, indicating that it's an adequate test. And his 6-minute walk distance was 202 meters. And this is his echo. So in the parasternal long, you just see the ventricle that's not particularly dilated. He does have some mitral regurgitation. And you also see in these views that there are some wall motion abnormalities and a severely reduced ejection fraction. His left ventricle is measured at 5.6 centimeters. And as he was evaluated, we have some of his other tests here. So his FEV1 was 1.8, so 52% predicted. The FEV1 to FVC ratio was 72% predicted. And this was deemed by pulmonary to be not preclusive to proceeding with any advanced therapies. Can you advance the slide, please? So as part of his evaluation, he had a CT, chest, abdomen, and pelvis. There was some consolidation in the left lung in the lower lobe that was thought to be infectious, possibly a pneumonia. Some calcified granulomas and pleural scarring. The abdominal organs were largely unremarkable. There was noted to be a severely calcified abdominal aorta, some scattered retroperitoneal lymph nodes that were nonspecific. ABIs, the toe brachial index was normal. There was calcification noted in the lower extremities, but with normal toe brachial indices. So the interpretation was that no evidence of occlusive disease, but likely with calcinosis. His carotid duplex, non-stenotic plaque in the right common carotid, and a 50 to 59% stenosis in the left bulb and internal carotid. On renal ultrasound, his kidneys measured normal size, and there was no increased echo texture in either kidney. Colonoscopy, he had some polyps that were removed and nothing preclusive. So again, as part of his evaluation, he had a right heart catheterization done, and these are his hemodynamics. So his right atrial pressure is 10. PA pressure, he has a mean PA pressure of 29, so mildly elevated, a wedge of 29, and that gives him this is in the context of a mean arterial pressure of 73, giving him the other hemodynamics listed on the right. So a cardiac index of 1.8, a systemic vascular resistance that is elevated, TPG of 8, and a PVR less than 3 Wood units. So putting it all together, we have a gentleman, 72 years old, who has end-stage heart failure. He's New York Heart Association Class 4, and he was started on inotropes, but he's Class 4 despite being on inotropes. Poor functional capacity demonstrated by his 6-minute walk and his CPET, with frequent hospitalizations. Comorbidities are primarily diabetes and his significant coronary disease, and with his anatomy and his multiple interventions in the past, he's not a candidate for further revascularization at this point. So, what would you do next?
I'm going to jump in.
Nothing.
A couple things to make sure that the crowd, everybody who doesn't do the evaluations, make note is there are certain key features which we use for decision making. The VO2 max If it is less than 12, then that's an indication for bad enough heart failure that you qualify for transplant listing in our mind.
Before you get into that, Arvin, look, I think the first decision, right, is, I mean, we state he's not a candidate for further revascularization. I think, that's an important distinction, right? I mean, he's had 3 prior operations, so he's had both mammaries, he's had 1 radial artery, so conduits are an issue. His ventricle is already slightly dilated. I can't remember his films exactly. Clearly, I don't think he's a surgical candidate. He had mostly scar, very little ischemia on his testing. Hesh, you wouldn't offer him another operation, would you, based on that information? So then the only other thing is whether there's some sort of percutaneous intervention, and I don't know if any of our interventional colleagues are here, but
You probably won't do by the fact that there's only less than 10% ischemia with a lot of scars. So yeah, I think there's
but I think that's important, because that's certainly the initial steps we went through before we go towards the advancing. I think the other things against further coronary revascularization or his moderate pulmonary hypertension that he's already got, his ventricle's already dilated. So hence that's the discussion, sorry.
Yeah, no, I think that's a key distinction. End of the day, you have a gentleman who's getting a bunch of evaluation. More important than all that, the question is, why is he here? How much of an impact is it in his life? It's NYHA class 4 despite inotropes. He's on inotropes. No one tried to wean the inotropes. The definition of inotrope dependency is 2 attempts of weaning, historically, but I think that there's some medical decision making. And as Dr. Scheinin was pointing out, you want to exhaust all options, which includes revascularization, optimal medications, and then the markers that we talked about all day, of which, the VO2 I wanted to just highlight, and then the PRAs, which were listed over there, are panel reactive antibodies, which are an immune marker. If they're too high, then they're risky for transplants. I think I just wanted to make sure those 2 things are understood by the rest of the crowd. But next steps, you want to take?
No, I mean, I would just make a comment in terms of the decision of that he's not a candidate for percutaneous revascularization. I would make that decision based on the angiogram, which I granted now we can say today there is nothing to revascularize, but I wouldn't just believe a nuclear stress test with these findings, right? So the amount of ischemia scar is over 30%, is significant. If he were to have a lesion that was obstructed by the angiogram, that was amenable to revascularization, I probably would consider doing something. And you can evaluate ischemia by MRI, not only accept that. So, but if he doesn't have anything anatomically, then it's an insignificant point.
But you bring up a good point. I think none of these tests for ischemia are perfect today. And we've seen many patients where even though the nuclear stress or something indicates mainly scar, anatomically they're a good candidate for revascularization. And clearly we've seen patients improve. So I agree with that. But I think we can assume that.
Yeah, so assuming that the anatomy is not suitable for anything percutaneously, then I guess that's not it's an irrelevant question, actually. Perhaps if I would have done that, an angiogram, there's no reason for me to do a non-invasive test and put the patient at risk of doing that. Right?
Great. Brian, anything surgically to offer him right now? Or?
He's like I said, he's high risk for anything. We're not going on to the debate about heart transplant or LVAD at this time, right? We're just looking at things that we can do.
I think it's a good point to do that once you guys get an initial discussion, because we'd love to hear from Dr. Torre.
Just so we've exhausted all options.
Yep.
In a way. I don't see anything else we could do besides the next step.
So maybe there is one, Brian, and that is, who was taking care of this patient before? Because I think it's very frequent, and when people are not properly taken care of, when they come into a specialized program, it doesn't have to be this program, but people that understand heart failure, you can improve their management significantly. Yeah. So the doses are minimal doses. It's an insignificant dose of an ACE inhibitor, a beta blocker, and very high doses of diuretics with perfectly good renal function. So, I mean, I guess one could make an argument, but even before making a radical decision, a trial period in a center that's dedicated to do heart failure, in a clinic with proper follow-up will be important. And people that go into clinical trials, if they just go on the placebo arm, do get better because of proper follow-up. So everything else we're going to do is going to be high risk, whether we do.
But you're exactly right. So he was followed here in Houston, but at an outside hospital. not in a heart failure center, by a general cardiologist who's been taking care of him for years. So he initiated therapy, but he understood he was getting beyond his level of comfort to take care of him. So that's why he referred him in here. So I think you're exactly right. So the next step is optimize his medical therapy, as Jerry talked about a little while ago.
No, I mean, assuming that Dr. Easter did perfect care and pushed the beta blockers and the ACE inhibitors and nothing else can be done, then the question is,
So
we have three options.
Yeah, so let's just for discussion's sake, not assume, but he was cared for here, optimized medicines the best we could, intolerant to higher doses of beta blocker, poor functional capacity, high-grade symptoms. He's 72. I mentioned that just to highlight the reality. But, so I guess it's going to be important. Would you consider transplant? And Dr. Torre, I want you to go through your transplant consideration for a patient like this.
No, I will. So,
Although his,
you want me
although
to?
his exertional tolerance is limited, he is in good shape.
Okay,
He's in good
terrific.
shape, has good social support, family history.
So age alone would not be the most deterring factor, right? But I think the most critical thing for me is to have a conversation with the patient and the family and find out what he wants. Because I don't think patients understand what it means to go to transplant or to go to VAD. Sometimes they say they don't want to die. Not everybody, but most people will say they don't want to die. But the price that you have to pay for that is not understood. Now, we see people day in and day out, and we are not playing the other part. But I think if I were to have a conversation, and I'm totally convinced that the patient is willing to go through and understand the risks, and I'm not going into vital transplant, because at the first level, I just want to make a decision. I mean, is this someone who's willing at this age to do more and accept the risk associated with it? So if the patient understands and the patient has good family support, and this is not a simple conversation. I mean, this will be a very critical, important step, and it may take more than one visit. Then I would definitely consider him for advanced therapies, and then I'll go into which one I would prefer.
But what's particularly important in a guy like this, he's 72, he's had 3 prior sternotomies, is to get it right the first time, as opposed to some of our other patients where
Sure.
we don't know their social situation, and we're kind of forced, so we need to say, put a VAD in as a bridge to decision, as we call it. I think in a guy like this, that's not an option. We have to decide up front what his surgery, if anything, is going to be, whether it be transplant or VAD, because that's going to be his only shot, right?
Sure.
I think we're not going to bridge him to transplant.
Right, but he's not at low risk for either VAD or transplant. So understanding that he may be in the ICU, that he may develop renal failure, that he may develop RV failure, that he may die in the ICU with drips and intubated, if he's not willing to accept that risk, then the best option will be on medicines. But if he's willing to, I think that there is a reasonable chance to go.
I think it's important to actually stress that fact that sometimes you have to overcome your own bias, because there are a lot of times I see, oh, this patient is old, he's not going to do well. I think the risk discussion takes a little more intense effort, and we as physicians have to fight that bias and provide objective data, because I think there's preclusive risk, which if you say that there's preclusive risk, but it is an acceptable but a higher risk, as Dr. Torre said, you have to sit down and have an intense discussion so that they understand and not rush into the surgery or not offer any of the options. Because, right, it's always easy to say no, and no one's going to blame you if somebody's older. But so it's careful. I
mean, I think that's the most important, maybe not be the most important, but certainly it's a critical part of what we do. And it really takes time and an art to develop that part, but the job of the heart failure transplant doctor is a lot of doing that and having an honest conversation, understanding risk and benefits, and trying not to put your bias into the decision, which is a big part of what many of us do sometimes.
Well, look, like it or not, the ethicist has become a big part of what we do. I mean, we have to deal with that. Not so much in a relatively stable man like this, but there's a patient in our ICU right now who's similarly old and sick and has, an Impella pump, which seems like everybody gets nowadays. And then the decision becomes much more difficult because an intervention's already been made. So now it's, do you continue, do you withdraw? And that makes it much more complicated. So I think having these discussions before that is very important.
I already gave you my bias. I think the most important decision is whether or not you should do more for. And frankly, whether you do one or the other, I think is less critical, to be honest with you. But there, all of us will have some biases that are very important in how we made the final recommendation. So VAD versus transplant. So Jerry showed us VADs on the roadmap trial. I mean, I tell you, 10, 15 years ago, people would believe that that's criminal. And today we accept it, and not only that, maybe we'll be doing more later. So there is no question that the technology and the outcomes have substantially improved over time with VADs. Unquestionable. 15, 20 years ago, when this technology started, people could not leave the hospital. They had machines that they had to push. Doing 5 cases in a year was a major undertaking. Today, 70 cases a year. People go out, there are 155 patients ambulatory. The technology and the outcomes have dramatically changed. So there is no question. So I'll give you that, Brian. There's not even a point.
I also have a picture for you in my presentation about that. From 10
So,
years,
but wait, we are not over. So, so if we would have had this discussion 10 years ago, there is no question. If you want to do more transplant, no, unquestionable. As a VAD, the first generation VAD for this will be criminal. People would not survive. They'll be dead in the operating room. And transplantation has clearly a long-standing history. It's effective, reliable. Unfortunately, here in Houston, we're sitting with major work has been done in VADs and transplantation. So we're biased and have a strong bias for both. There are places that have biases for one and the other. But here, we have a strong biases for both. So I think the future for transplantation is even better. So we'll touch into that a little later. So this is what happened to technology, right? So I was not able to afford a phone like this, but in 15, 20 years, now this is a computer, it's not even longer a phone. So that technology is identical. These old machines were pulsatile, they make noise, they harm the patient. They were ulcers, the people will have major ulcers, and the noise was so bad that people could not even tolerate the noise. And these devices failed, and every case had to be replaced within a year and a half. So this technology evolved to this. This is a HeartMate II, and this is a HeartMate III. So today, we're going to see that maybe between these two, the outcomes that we have today are very, very good, similar to transplantation. So 10 years ago, if this was a question, out of the question, it couldn't work. But with this, and maybe what's coming in the future, perhaps it's more competitive. And you can see this in this slide. So these are outcomes as they have changed over time. This is just to show you the people on medical therapy. In this category of patients that we're discussing, they all be dead in 2 years. Everybody dies. And with the first generation of VADs, maybe you have a 50% mortality at a year, but then over time, 80% mortality. So first generation devices, they are not working. But look at what happened with the most recent data, or one of the most recent data, but everything else pretty much looks the same. You look at 1 year survival with a VAD, 90%. So that's actually very good, because what I will show you with transplantation is the same. So if you look at 1 year survival, it's close to 90%. 90%. Here, 94%, 93.5%. But if you look, see, this is quite interesting. You have 5-year data, 75% survival. That is maybe getting there, but it's not quite there yet. So 72, how many more years you want to live? 10? Actually, 72 may be young. The president is 71 or 70, right? So how many more years? I don't know. But clearly, long-term data, VADs today do not compare with transplantation, just because of the time, the years that we've been doing transplant versus VAD. So if you are fair today, in a patient like this, you say both techniques may afford him, or both strategies may afford him a 90% chance of survival. The risk of surgery with a VAD and the risk of surgery with a transplant probably going to be the same. They have to go through the sternum unless you consider alternative options for surgical placement of the VAD. You create a surgical problem at the time of surgery, be a big problem for both. I would argue that if you have immunosuppression without proper vascularization, maybe the risk of external wound infection may be greater, but the possibility of infection with a tether device may be more significant. So if you accept 90% survival, both options may be reasonable. So how do you decide? I mean, how would I decide? So we started a conversation that I did not necessarily intend, but I want you to maybe read over this and make the following point. This is a paper that came out of a group at Stanford, published in PLOS ONE in 2014. It says an overwhelming percent of doctors in that study, 88, almost 90%, said that they would choose no code or do not resuscitate orders for themselves. And though other studies have shown that most Americans would choose to die gently and naturally at home, that's not what's happening. So what do I take out of that? So we put a lot of biases in what we recommend patients. But when we are on that side, perhaps the decision is different. So Brian and I started by asking whether this patient may not necessarily need anything, right? And I would add the question, I don't know what I would do if I was 72 years of age and I would be confronted with that decision. Frankly, I don't know what I would do. So you say, if I don't know, why would I impose a decision on a patient? Especially when they don't understand and they look at you as someone who can provide them with a better answer. So let's compare simply. This is a 30,000 feet overview of transplantation. Because my colleagues gave you all the very hard data, and I'm a very simple-minded, so I just want to make it very simple. So transplantation needs immunosuppression. Well, the LVAD patient will need a machine, and will have to live with a machine, tethered to a battery, having to change the batteries. These guys need frequent biopsies. And I remind you, not very comfortable. People hate it. They don't like biopsies, so transplantation comes with a cost. And you also have a lot of medicine side effects. But if you have an LVAD, you have a risk of stroke, you have a risk of bleeding, risk of infection, and risk of device malfunction may not be inconsequent. And you still have to take a lot of medicines. And I couldn't find any more here in transplantation. So there are some, but I couldn't find many more, right? So there are, and what's interesting, see, this is a nice slide Dr. Esteve gave me, and I was looking, you sent me 226. I didn't know what to do with that information. But I picked, as if I was a lawyer defending a case, so I picked this one. This is the functional status of surviving recipients by the Karnofsky score. Now, I forgot what that score was. But what's important to tell you is that all the green, yellow, and red, these are guys that are doing okay, that are happy with the functional status. Of course, not everybody's perfect, but if you look, 80+% of the patients that receive a heart transplant within a year, they say they are very happy, very satisfied with the transplant, and they can do most of the things that they want to. It's pretty remarkable. I'm not sure, and we can talk about it with VAD and VAD, all these criteria, and Dr. Packer, I guess, just left, but the VAD companies, they lobby very aggressively, and they are very good at their job, and they will show you data that looks terrific. Now, I'm not sure that that is the case. But this is factual data from thousands of patients, not in a handful of patients. So people with a heart transplant do very, very well. Some don't make it, less than 10%. So I think that without any question, I'm making an argument that transplantation will be better because the quality of life in someone at this age will be better. But I want you to consider this other option. Because at the end of the day, I think, and I didn't mean for this to be an ethical discussion, but unfortunately, you threw a case where this may be the most fundamental part of it. And say, just let me read this to you. It says, a big disparity exists between what Americans say they want at the end of life and the care they actually receive. More than 80% of patients say they wish to avoid hospitalizations and high-intensity care at the end of life, but the wishes are often overridden. So guess what group has more hospitalizations? And what group has less hospital? So heart transplant recipient has less hospitalization than a patient that has an LVAD. So just for you to remember. So I think that in general, to be fair, both strategies are okay. But a simple strategy that would have a very predicted long-term success that will give total freedom to the individual, perhaps is heart transplantation. And I would definitely favor that, because I put myself as if I was going to receive the therapy, and if I didn't want to die, if I wasn't ready to die, I would take heart transplantation over VAD. So I'll leave you with this, because I may not be the only one that's questioning in scenarios like this the idea of destination therapy. So this is a paper that came out in JACC, where, and we didn't talk about cost, which is not an issue today, because Dr. Packer said that we just make more money. So I guess cost is not an issue. But there is an ongoing debate about the ability to do devices in people at the end of life, and whether or not you're willing to take, or patients really fully understand what they are committed. And I'll just remind you with the last slide that the study, the +1 study says that people, over 80% of the patients, don't want to be at the end of life in an ICU, suffering with intubation, with renal failure, with antibiotics, or strokes as a consequence of it. So transplantation in the future is going to be even better, fewer side effects with medicines, better immunosuppression. There will be tolerance. We will be able to shut down the expression of alloantigens by using Sirna technology. There is no question. And I think the organs will produce organs that are less immunogenic. So I would definitely go for heart transplantation.
Guillermo, maybe one thing you can comment on. I think we view the therapies as equivalent, but the one part of it that's not is organ availability. We're a little bit spoiled in this part of the country because we have relatively short wait times. I think that slide. Well, no, I think it's a very important distinction. If you live in the Northeast, I think there's nobody that gets a heart transplant that does not have a VAD, because their wait times are so long. So we're faced with the decision, and where sometimes, look, I'm more aligned with you. I think transplants perhaps underutilized a little bit, but we're faced frequently with the decision, we have a sick patient who's decompensating, we do what we can, but unfortunately we don't have the organs. So I think that's part of the equation that has to be factored in making these decisions.
No, I think you're absolutely right, Scott. Now this patient, however, at GFR 54 doesn't have RV failure. I think that I would, and he's stable on inotrope, not having a lot of VTVF. I would probably give him the benefit of waiting as a status 1B and C, and be very proactive if he was going to deteriorate, and have a backup plan. But I would first opt to give him the opportunity of heart transplantation.
Good point, because if we were in another part of the country, he's a blood type O, even as 1A, he'd be waiting in the hospital over a year.
All right, I'll go ahead and try to keep this short. I know we're running behind. Now I'm going to give you a brief presentation. I'm going to show you a lot of nice pictures. I like to keep it simple too. I'm not going to show you a lot of fancy graphs, but I will show you a few slides from that massive 230 slide presentation Jerry sent to us.
I wanted you all to have access to both slide decks to pull at your desire.
Yeah, I don't have any financial relationships with device companies, I can tell you that. We'll discuss the exciting HeartMate III trial that's just finished its main enrollment, over 1,000 patients, which we were a big player in. So this is just like a little VAD education for a few minutes, and then I'll present some of my arguments. As you know, trying to keep this basic, VADs are intended as bridge to transplant or destination therapy. And as Guillermo alluded to, about 10 to 15 years ago, the devices were questionable, I have to admit. There's been a trend towards equal destination therapy versus bridge to transplant. And in fact, we project that majority of LVAD implants soon will be destination therapy. Now here you go, Guillermo. Here's your slide. This is patients early on with VADs, for 10 years plus, and they're stuck in the hospital, no quality of life. You're correct. They get infections, and the devices, these pulsatile pumps, don't do well. So I wanted to just show you that this is, and I think a lot of this is perception too, and that's why I'm glad everyone's attending today. Even despite the improvements in continuous flow technology and exciting new HeartMate III, the old days still haunt us. And there is a perception that VAD is bad. You're going to be in the hospital and you're going to die a horrible death, but that's not true anymore. And here's some of our patients, some of those 150 patients outside greater Houston area and even other states that are enjoying their life. And actually, Guillermo, you can look here too, and this is what I'd ask this 72-year-old, what do you want? I mean, do you simply want to go play golf? Do you want to work in your shop? I mean, do you want to see your grandchildren? These are important questions that you have to ask, especially as you get in your 70s, as you get older, even with heart transplantation, but especially with VADs. Here are the old pulsatile pumps. Guillermo showed a similar slide. You can see the evolution in technology. I'll turn your attention to your right. You can see the changes in the miniaturization in technology. Smaller is better. Not always, but it's just like with microprocessors. We're almost pretty much gotten as small as we can get. Here are some images of continuous flow pumps. On the right-hand corner, upper right-hand corner is your HeartMate II, which is our workhorse, FDA approved for bridge transplant and destination therapy. In your left-hand upper corner, that's HeartWare, which is approved for bridge transplant. And of course, the destination trial is finished. They're waiting for approval, hopefully. And in the bottom right-hand corner is HeartMate III, which is still investigational. In the interest of time, the other two pumps have been investigational as well. No VAD talk is complete without mentioning our pioneer, Dr. DeBakey, a lot of the rich history of heart transplantation as well as devices originated here in Houston. Dr. DeBakey has been credited with developing one of the first continuous flow pumps in a collaboration with NASA. You work with Dr. Noon as well. The latest iterations of Reliant Heart Assist 5, we are part of that trial. It's similar to the HeartMate II as a flow sensor on it, but it's still investigational. But I wanted to talk about the history. HeartMate II, just to show you a pretty picture here, you can see that it drains blood of the left ventricular apex, puts it back in the aorta, has a little drive line coming out, and a controller that the patient wears on his belt. And actually, you'll be impressed, we have this LVAD celebration every year. We can't tell who has a VAD because it's concealed under their clothing, and they're all walking around, they're eating their free food and enjoying the celebration, which we have one coming up soon. I'm just screwing this up just like Jerry was doing. Here's the HeartWare. As you can see, the pumps are getting smaller. This is an intrapericardial pump. Once again, it's still waiting approval for destination therapy. Another pump we do implant. You can see how small the devices have become. HeartMate III, that's our latest iteration. The new improved are different from HeartMate II. It works by magnetic levitation. It's more of an intrapericardial pump, as you can see. It's a little bit easier to implant surgically. Same concept, has a driveline that comes out as well as a controller. And for your budding physicists out here, I like to show these fancy diagrams that it generates a better flow, so to speak. It minimizes shear stress and avoids stasis, so it has better hemocompatibility. And also, it creates this artificial pulse by varying the speeds of the rotor. And you can also see there's less contact with when you're using this magnetic levitation technology, less contact with blood with the artificial components. And we hope that it minimizes shear stress, and this may translate into less pump thrombosis, which is what we're seeing on the early data from the Momentum trial. And we may see less GI bleeding. We're not sure yet. We have to analyze the entire cohort. And more importantly, less pump thrombosis. And that has been a problem with the HeartMate II. When you talk about all the complications, you can have pump thrombosis in about almost 8 to 10% of your population. So we do pump exchanges probably about every 6 weeks. An article came out of the New England Journal of Medicine at the end of last year. This is the first 200 plus patients in the HeartMate III trial. And I'll show you one conclusion that they came up with. They had no pump thrombosis in this first 200 plus patients. Our group is also going to be featured in the late-breaking trial announcement at the upcoming International Society of Heart and Lung Transplant. And also in the trial, we finished number 7 in the country. We enrolled almost 30 patients. And we were very active and participated well, I think, and we're well represented from our institution. Just a take-home message from this slide. Basically, there was no pump thrombosis in the HeartMate II group. You did see almost a 10% incidence, so this is a serious problem, obviously, with the current pump we're using, HeartMate II. Just a few blurbs about our program, since we're considering this patient for our VAD program. I'm not saying ours is better than anybody else, but I think this shows the trend across the country. More and more of these pumps are going in. If you look at around 2006, or around 2009 or so, I think that's when the FDA approved the HeartMate II for destination therapy, around that time, and you can see the numbers have exploded. And we are predominantly a destination trial. And you can look at the blue bars show increasing implants for destination therapy indication and less for bridge to transplant. 1 year survival, yes, we're approaching, right now, the latest statistics, we're about 90% roughly. And another thing, when you look, so we're talking about quality of life. I don't want to hang my hat on a survey that's sent out. But whoever was filling the survey out is relatively happy. Anyway, okay, to move on. Survival with LVADs, 75 to 80%, that's in DT patients. Okay, that does include the usually younger BTT patients. Improvement in quality of life, metrics that's continued in the current era of continuous flow VADs out to 2 years. And I don't have time to show you all the fancy graphs. Guillermo's right. The device companies are very aggressive in marketing, and they'll show you how everybody's doing so great, and they'll show you the pictures like the one below. But that's actually one of our patients, believe it or not. There is a challenge with VADs as far as adverse events. We haven't fixed that yet, but we're getting better. And I think that, especially with the HeartMate III, with a decrease in pump thrombosis, that's going to be a big game changer. Real quick, just a couple. LVAD versus transplant. I found that beating heart for you, Guillermo. I'll send that to you. Okay, so just real quick. Heart failure is bad. If you don't do something as they get out class 4, they're going to die, despite even optimal medical management. I don't really have to show you that. It goes without saying. And here you go. Here's that little graph. The number of heart transplants reported per year. There's just still not enough donors. Despite the increase in the U.S. population, it still remains relatively about the same. And you're going to continue to have more and more patients that require the need for surgical intervention. And we're showing some of the similar graphs. This one's a little more updated. It includes 2013 and 12 data. But you can look at the top, if you look at the graph on your left on the top curves, these are actually the destination therapy as survival in months, and I think Guillermo's covered that pretty well. This is another slide that's repetitive that Dr. Estep showed. Just want to look at the relative contraindications. Age is not an absolute contraindication. I'm not against doing heart transplants in patients over 70, but once you hit 72 or above, I start to think twice about it, and I'll show you my argument here in a minute. But you can see the obvious specific, and also this patient also has diabetes too. That's a risk factor. You ought to mention that. This is a slide that I took, and this actually looks like the overall experience. I know Guillermo showed you the one from 0 to 5 years, but I just pulled this one slide out, and you can look at the patients that are over 60 to 70. They do start to drop off later on. This is not necessarily an argument for not doing it in older patients, but also the experience in older patients is still, when you look at the 70 plus, 938 versus the over 100,000 or almost 100,000 patients. That's a small cohort if you think about it. Now I wanted to show this slide. This is from the Social Security Administration. As you get older, you have a higher chance of dying from other causes, okay? Now here's the curves. I want y'all to look at this. You can see how when you get older, you're going to die of something else. Now, admittedly, heart failure is one of the number one causes of death, so that's probably helps drive those curves in, but you don't live forever. My point is, you can do all this. You can put a transplant in a 72-year-old. You have to ask yourself, I mean, here we can talk about ethics too and philosophical reasons and all that. Should we be doing heart transplants in older patients like that? Because that population is only going to continue to increase with all your fancy medicines that y'all talked about earlier. We're going to see more of this patient population, but you're also going to continue to see the 30, 40, 50-year-olds, even 60-year-olds that really need these organs. So even Dr. Scheinin alluded to that too. There's still a shortage of organs. We're going to need device solutions. Here's a slide borrowing from Thoratec. Several articles out there looking at survival. So we can talk about survival benefit. Yes, Guillermo already touched on that. 1 year, dead even. 2, we're getting closer though. But going out 3, 4, 5 years, I think the jury is still out, but I see it's approaching, the survival is going to be equivalent, I think, at least around 3 years. I'm hoping. We'll see. And I wanted to leave you with this quote. This is from Mandeep Mehra. The frequency of heart transplants in patients over age 65 has not risen dramatically because of an acute shortage of donor hearts, strict eligibility standards for potential recipients, and caution, we didn't talk about this too much today, and caution at transplant centers that do not want to jeopardize success averages with risky operations. What is our expected survival in a heart transplant program today? It's high. I mean, we're supposed to be,
In excess of 93% to maintain our
how
metric.
about 1 year?
1 year, in excess of
Okay,
93%.
so 72-year-old diabetic patient, okay? He survives the surgical insult, so to speak, which he's going to be risky. 4-time reduced sternotomy. His lungs aren't perfect too, by the way. But let's say he gets through the operation. We get him out of the hospital. Then he has a stroke 8 months later because he's dying of natural causes and he has some predisposing factors. So I can make that argument. And I know that's a whole nother lecture, but I just wanted you to focus on some of these points. And lastly, we can't keep a transplant program open if we're doing a bunch of heart transplants on 72-year-olds. We just can't, in my opinion. And that's it at this time. Thank you.